housekeeping remarks, and then we'll get right into introductions as people are signing on.
Great, thank you, Linda, and welcome to everyone to our panel discussion, Social Determinants of Health, an examination and discussion about nutrition, food access, and obesity. We're so pleased to have our 4 panelists with us here today, along with our attendees who are joining us from all over the country. Common Threads is a national nonprofit organization that provides cooking and nutrition education programming to children, families, and educators in under-resourced communities in our 12 markets throughout the country. Throughout the pandemic, we've continued to fulfill our mission by providing digital programs, including our 10-day virtual summer camp, while also supporting community-based food distribution efforts and advocating for policy change to help children and families who are facing difficulties during COVID-19. We set up today's panel discussion because it is our belief that your zip code should not limit access to healthy and affordable food, nor increase your chances of developing overweight or obesity. Before we get started, we'll cover just a few quick housekeeping items. Most viewers will probably prefer to use speaker view so that you can see the panelist who is currently speaking. You can access this by clicking the speaker view icon in the upper right-hand corner of your Zoom screen. The Zoom is set up so that all participants are muted and screens are turned off with the exception of our panelists. Today's session is being recorded, and it's also streaming on Common Thread's Facebook page, where it will be available for people to view on demand after today's session. And finally, we'll be taking questions for the panelists. So if you do have a question, please make sure to submit it in the Q&A window at the bottom of your Zoom screen. And now our co-founder and CEO, Linda Novick O'Keefe, who will be moderating today's panel, will introduce our 4 esteemed panelists. And thanks again to everyone for joining us.
Well, I first want to start off by thanking each of the panelists for making time and space today to have this conversation. We're thrilled that each of you were able to participate. So I'm going to just jump right into it because I know that this is going to be a very robust conversation. And I'm going to start with Dr. Fatima Cody Stanford, who's an obesity medicine physician. And so Dr. Stanford, you're an obesity medicine physician scientist and Harvard Medical School faculty member. Can you tell us how long you've been in this field, why you chose this specialty, and how important this field is for the future of tackling obesity?
Absolutely. First of all, thank you so much for having me here today, really to discuss, I think, this very, very important issue. So I was drawn to this field, I would say about 20 years ago was when I started conducting research looking at overweight and obesity, predominantly in communities of color. I was born and raised in Atlanta, Georgia, although obviously currently located in Boston. And what I noticed was the disproportionate rise in obesity amongst communities of color, particularly the African-American community, and with specific focus on Black women. And so as a Black woman, this was of interest to me and explains why I did do a 3-year obesity medicine fellowship after doing my training in both internal medicine and pediatrics. So I came to Boston to really focus all of my time and attention on providing care to both pediatric and adult patients that have overweight and obesity. One of the things that I think is paramount to our understanding is recognizing obesity for the disease that it is. Indeed, I was the speaker before the American Medical Association acknowledged it as a disease back in 2013. That was while I was in my fellowship training. And then now really focusing on how can I leverage what we know about this disease, what we know about evidence-based treatment and therapies for those that have overweight and obesity, and how I can begin to spread and promote what we know in terms of evidence-based treatment of obesity. And so this is kind of what brought me to the space, why I'm in this space, why I remain in this space, and why I see this as my life's work.
Thank you, Fatima. Dr. Derek Robinson, you're up next. At Blue Cross Blue Shield of Illinois, where you are the Blue Cross Blue Shield's Vice President and Chief Medical Officer, you're in the midst of leading the organization towards improving health equity. We've been talking so much lately about health equity. Can you describe what success looks like when health equity is achieved?
Thank you so much for the opportunity to join this panel and participate in the discussion today. Certainly, we know that improving health is something that's very important, not only within the healthcare community, but it's also important to our economy. And we have a number of subpopulations and communities that don't enjoy the best opportunity to be as healthy as possible. And so I think it's very important that both within the healthcare industry and the health insurance industry and beyond, that we look for those levers that we can pull that positions everyone to be as healthy as possible. Often folks don't really talk about food as being medicine, but we certainly know that what you eat and your physical activity and many of the other things that we'll talk about today that contribute to your health status and weight are really important in terms of staving off some of the chronic diseases that particularly plague many of our under-resourced communities across the country. And so certainly when we're able to begin to address many of these social determinants and improve them, particularly for those that are most vulnerable, we move ourselves closer and further down the road towards health equity. I think the challenging thing for us also to reconcile is that many of the other social determinants that we face and battle collectively did not occur overnight. They occurred over long periods of time. And so we'll have to have significant endurance as we work together to really peel back some of those really entrenched determinants that make the challenges that we're facing around obesity, for example, so recalcitrant. But I appreciate the opportunity to join some of the nation's leading experts in this particular space of improving the health of communities and doing so with great resiliency and optimism.
Well, we're delighted to have you as part of this conversation. Dr. Ed McDonald, you are a gastroenterologist. You are also an assistant professor at University of Chicago. You're also a trained chef. Can you talk a bit about your experience at Project Brotherhood, which I love hearing about, and how it increased your awareness of the impact of social determinants of health and the effects of nutrition on health and disease? We'd love to have you share more with us about the community initiative that you helped create and how your experiences still guide you as the Associate Director of Adult Clinical Nutrition.
Okay, well, thanks again for having me. So for me, my interest in social determinants really occurred when I was growing up here in Chicago. So I remember being young and going to church on the south side of Chicago. And every Sunday I would hear about people who were sick and sudden with diabetes, or someone's had a stroke and someone, has had a heart attack. And I remember every Sunday we were praying about the same things. And I believe in the power of prayer, but I also believe in the power of prevention. And for me, as a young child, I was like, why are so many people at this church getting diabetes? Why are so many people having strokes and heart attacks? And that's something that stuck with me throughout my undergraduate education and subsequently medical school. In medical school, I went to Northwestern, and I was one of the few African-American men in my class. But I remember going to lectures where we would talk about the epidemiology of different conditions that affected Black men disproportionately. And I remember sitting in the front row for a lot of these lectures. And every time the lecturer would discuss one of these conditions, be it prostate cancer, be it high blood pressure, be it stroke, be it colon cancer, they'd always say that there's a nutritional dietary component. But we never really got any details in terms of how do you eat, what is the healthiest way to eat to decrease your risk for some of those conditions. So for me, I was really interested in how do you prevent some of these conditions. And I ended up getting involved with Project Brotherhood. They were a clinic specifically focusing on Black men on the south side of Chicago, and they were very interested in prevention. So I, as an eager medical student, began volunteering. And the first time I went there, I never saw anything like it. It was a clinic where the physicians did not wear any white coats. The physicians, who were all Black men, just dressed in regular street clothes. Like literally people with sweatpants on and stethoscopes. And they had barbers in the waiting room cutting hair. To me, it was phenomenal. So I'm actually getting my hair cut, talking to patients about how to manage their high blood pressure. and you had barbers behind me kind of echoing everything that I was saying. So for me, I realized that a lot of the reasons why people had high blood pressure, specifically in that clinic, a lot of it had everything to do with their lifestyle. And most of what we were doing in that clinic was really trying to figure out ways to reach people to help them address some of the social determinants that affect their lifestyle. And that stuck with me throughout not only residency, but also my career in general. So at Project Brotherhood, I had a lot of patients who didn't really know what to eat. And I actually started doing cooking classes within that clinic. Because again, if you can have barbers come in and talk to patients, I should be able to actually cook. So I started doing it, and I saw that people actually were engaged. And that inspired me eventually to go on to culinary school, where I now continue to provide that education for my own patients here at the university.
Thank you so much. And thank you so much for being here. Dr. Garth Graham, so you're very familiar with minority health. You ran the Office of Minority Health under both the Bush and Obama administrations. As the Vice President of Community Health and Impact for CVS Health, can you talk to us about the importance of addressing specific community health issues that minorities face in this country with attention to obesity and chronic disease?
Sure. And thank you, Linda, for, again, I think Derek articulated it well in terms of really an esteemed, just amazing group of folks. And I, I'm in awe of a lot of the stuff and that Fatima, Ed, especially his work as a chef, and hearing about that is just not only interesting, but exemplary. And then certainly I think Derek and all the work he has been doing, both locally and nationally. So, I have my view on this issue on social determinants of health, has both evolved and stayed the same in terms of what's been occurring in Black and Brown communities for a long time. Certainly, we know, people talk a lot about zip codes mattering more than your genetic codes, and all of these concepts that emphasize that where you live dictate not just how long you live, but the kinds of lives that you live. And this clearly not only trickles down, but is defined by what you see a lot in the pediatric populations. What's interesting now when you look at what's happening with COVID-19 is we know that of all the risk factors that put children at risk for complications for COVID-19, including the multi-inflammatory syndrome, is obesity. So we know that the concept around obesity is driving so many of how and how long, and again, the kinds of quality of lives that the children live. And now with COVID-19 is putting them more at risk. And of course, as many of you already know, the majority of children who now suffer complications or advanced disease from COVID-19 are Black and Brown communities. Again, exacerbated by the social determinants of health, which again are complicated by, again, the clinical factors. So what does that all say to me now? It means that as we've known historically, and we know now, addressing these social factors are even more important. And certainly I think from our standpoint, in a multitude of different ways, there is a variety of different approaches that we can take. And I think we'll get into that as we talk further. But there's no doubt, I would say now more than ever, that these community factors, the social determinants of health factors, the kinds of places where people live, take even more importance. And I'll just give you one last point along these lines. As we've been testing, particularly in Black and Brown communities around COVID-19 across the country, and kind of being on the front lines of the pandemic in a very different way, one of the things we've seen, I think, early on is the trajectory of COVID-19 has been taken in Black and Brown communities. And I often say this, I think it's a different disease. I think what we're seeing in Black and Brown communities is a more severe, a more impactful, and again, not just clinically, not from a public health standpoint, but even what you're seeing economically, is a different kind of a phenomenon. And the challenge with this phenomenon is when the clinical part goes away and the social and economic parts really start to take root over the next 6 months, a year, 2 years, 5 years, even longer, this will then disproportionately impact children and their ability to both live a fruitful and healthy life from a number of different ways. So not to go on and on about that, because I think we'll have more time to talk about this. But right now, I think we need all of our best minds really thinking through how we can ameliorate some of these initial impacts. But then certainly I think for Black and brown children, there is a risk here that we may see something that goes on many, many, many years, even after the initial waves of this pandemic is under better control.
Thank you, Garth. And I'm just going to very quickly level the playing field, as some people here might not be familiar with social determinants of health. Very quickly, so as far as social determinants of health, and please, all of you correct me if I get something wrong here. But really today we're going to talk about the forces, systems that shape our life and environment. So we'll place specific attention on access to fresh food and green space, access to healthcare. Right now, over 1 in 3, approximately 1 out of 3 people have obesity or chronic disease. Those rates are higher in under-resourced communities and disproportionately affect Black and brown communities. As far as children and adolescents go, the prevalence of obesity among 2 to 5-year-olds was close to 18.5% and increase as the kids get older. And then the National Heart, Lung, and Blood Institute reported that there's about a $50 billion a year cost in healthcare costs attributed to cardiometabolic diseases, and cardiometabolic deaths account for close to 45% of all deaths. And 20% of heart disease, stroke, and diabetes costs are due to poor diet. So jumping right in, and I'm going to open it up to all of the panelists to answer some of these Q&As. So please just let me know who would like to answer this. The first question is, for a number of years, obesity rates have been increasing across the country for both children and adults. In response, a lot of that, the research has been conducted, programs have been implemented, and funding has been released by both private and government agencies. It seems like these efforts potentially might not be working or not working fast enough. What else needs to be done?
Well, I want to jump in here. I think that the major public health thing we're not doing is looking at the parents themselves. So what we need to know is that weight is more heritable than height. And I like to say that in my talks and say it again. So weight is more heritable than height. So if we know that we have a population of individuals that have overweight and obesity, and they conceive a child, their likelihood that they will pass that obesity on to their child is on the order of 50 to 85%. So that means that what we could do is modify the parent's preconception, which means we need to be targeting all children, whether or not they have overweight and obesity, because their likelihood of developing it, if there is a strong family history, is indeed high. And that's something that we're not doing. We're targeting patients or persons, subjects, if you're looking at studies, post them developing the disease of overweight or obesity. And it's always harder to start at that point once we actually have the disease process. Another thing that I think is, a strategy that we haven't been thinking about is how we can utilize evidence-based therapies actually that work. So for example, the American Academy of Pediatrics came out in October of 2019 with a strong statement supporting the use of metabolic and bariatric surgery in those pediatric patients that have severe obesity. Right now, we're seeing that less than 1% of pediatric patients that meet criteria for overweight and obesity, particularly for severe obesity for treatment by bariatric surgery, actually get access to those therapies. And I've published a paper that even show that when we're looking at those that are from racial and ethnic minorities, accounting for that Medicaid population, that it disproportionately is such that white individuals that have Medicaid get access to surgery, as even children, whereas Black or Latinx communities don't get access to that same care, despite what we know are higher obesity rates within those communities. So what we're seeing is problems with access to therapies that indeed work. And that even across the population as a whole, when we're looking at white, Black, Latinx, et cetera, we see that we're not accessing therapies that indeed work and modify one's metabolic state, metabolic health over the long term. We're talking about sustainability, not a crash diet, something that we can't sustain over the long term. Only with sustainability will we see changes in health status of population, changes in costs, et cetera. And so those are things that I think we need to be really mindful of when we're thinking about interventions. How do we first get the patient before they become the patient, before they're conceived, that preconception, looking at fetal programming, those ideas, and then extrapolating that to what we can do once that patient then develops obesity, those evidence-based therapies that have better improvement in one's weight and metabolic health than what we typically see in many of the studies.
And I also agree with Dr. Cody Stanford. So a lot of those disparities that we see in the pediatric population as far as access to bariatric surgery also exist in the adult population. And even for people who do have Medicaid, Medicare, oftentimes there's a difference in terms of the type of activities you have to engage in order to even qualify for bariatric surgery. So the insurance industry, or even the government to some degree, for certain populations, that actually we put hurdles in place in order to get them bariatric surgery. So for instance, here in Illinois, if you have Medicaid, you may have to, I may have to see you 6 times in a row, at least once a month, and you can't miss a month in order to qualify for bariatric surgery. And if you actually miss one of those months, you have to start over again. And that is a barrier that disproportionately affects people of color to some degree. And another thing that's also recently upsetting due to changes on the governmental level, at least the state government, for people who have county care provided by Cook County, you can't go to University of Chicago or any of the academic centers for bariatric surgery. You can only go to a county hospital or Cook County. So, and that's a change that recently happened. So there's patients that we followed for 6 visits, but now because of a change in the law, they have to go somewhere else and actually see somebody 6 more times before they can qualify for their surgery. And there's certain surgeries that people who are super obese may actually benefit, people who have super obesity may actually benefit from, compared to other different types of surgeries. And some of those surgeries are not offered at some of our county institutions, unfortunately. So that adds a whole nother barrier that people have to face when they're trying to seek care.
Yeah, and I'll add one thing. I always try to start off by being humbled. I think, Ed and Fatima are obesity specialists, and certainly I think understand a lot more about how this is driven, particularly in children. I'm a cardiologist, and my first introduction to a lot of the challenges was when I was training at Mass General at Fatima's organization, as I was going through my kind of initial clinical training. And there was a mentor of mine, a guy named John Rich, who's gone on to win all kinds of things. And John is a MacArthur Genius Fellow. And John kind of mentored me back in the day. He did a lot around Black men's health in Boston. We established a project looking at Black men's cardiovascular health in Boston. And one of the interesting things that started then, as I've seen as I've matured more through kind of professional training and otherwise, is a concept of how do you make healthy decisions the default decisions. And one of the things John and I think Tom Levis, when he was at Hopkins, and those folks who research all these the dynamics of urban environments show is the default decision for parents, but ultimately children, is ultimately an unhealthy one in terms of social conditioning. And this concept that, quite frankly, a lot of urban communities, there's a repetitive density of things like liquor stores, fast food, and Chinese food locations. And Tom Levis has this amazing study he did. Tom Levis is now dean down at Tulane, but when he was at Hopkins, did this amazing analysis of the tapestry in Baltimore, and similar to what John Rich, I think, showed in Roxbury and some of the relevant communities, is the density, the frequency, and also the access points for these kinds of locations ultimately make unhealthy food the default decision. And ultimately, I think from an upstream perspective, make it more challenging for those people We want to get involved in the things like Ed and Fatima are leading, and in terms of cooking and how to kind of make yourself healthier. And we did a lot of focus groups, particularly with Black men. And, there are a lot of men who believed in the concept of health, but didn't feel empowered to make healthy decisions because they had to go to work. And on their way home from work, there was A, B, and C, and, all of these kinds of things. So if you just even take a step back and think about the kind of environmental dynamics that are created at a 10,000 foot level, that's where we see a lot of the challenges. And I think there's a old model of public health that a lot of folks overuse that Tom Frieden published that shows that, at the top of it is clinical care, at the bottom is the socioeconomic dynamics. And we should really be investing more towards the bottom in terms of a lot of the socioeconomic consequences. I'll say one thing, we published a paper, this was again in the heart disease standpoint, showing, we published a paper 2 years ago in JAMA around what is really driving the outcomes in heart disease in Black and brown communities. And what we showed was that particularly when it related to deaths or related to heart disease, socioeconomic dynamics, more than your initial presentation for a heart attack, your clinical characteristics, more than any of these things, was the differentiating factor between Black and white death rates as it went to a 3 and 5 year time period. And that long soliloquy to say that this idea of, again, kind of the fabric of infrastructure, of social infrastructure that's created around communities is where I see some of the most challenging dynamics. And people always ask, is it genes versus location? And I always say location trumps genes anytime because of just how unhealthy we make locations nowadays. But I will say that until I heard Fatima's stats around the inheritance patterns, I was unaware. So I love panels like this because I walk away learning much more from my panelists than I have to contribute. So anyway, so my point of just making the concept around social dynamics being a factor that we should consider as well.
So that inheritance patterns. Oh, can I comment? So that inheritance pattern also not only entails the genetic information that we pass on, but also the behavioral information that we pass on. So oftentimes we see obesity within families, not solely because of the genetics, but also because of people are just passing on the same dietary habits and level of physical activity to some degree too.
And I would just add to the very fine comments that have been made already that, we're in a more technologically driven society now. So we've got folks that are in front of devices and phones and less mobile, which impacts our physical activity. And then I think layered on top of that, we also, take into consideration the significant marketing that goes along with some of the co-location of poor food resources that Garth referred to earlier. And so I think all those things come together at a sort of a perfect storm in terms of what we're dealing with today.
Thank you. So it's well known that in Black, Latinx, as well as some Asian immigrant communities, that they face a lot of inequities regarding access to fresh and affordable foods. So, and also in some cases, many individuals lack education about the relationship between diet, nutrition, and their health. Oftentimes, doctors see patients at a time when their health has really taken a downturn and are not addressing these things from a prevention standpoint. How do we restructure this common and typical health pathway that too many people are experiencing?
I like to jump in first, and I just wanted to tell all the guys on the panel that females come first. So I'm just going to do that. But no, one of the things that I really want to think about it, I'm sorry. That's so me. If you guys don't know me, you guys are learning me that are listening. One thing that I really wanted to bring up, and I think that, you know, Ed brought this up a little bit earlier, is approaching people where they live. If you're looking at the Black community, a lot of what the Black community typically does is spend a lot of time at church. Some of the behaviors in terms of what we like in terms of nutrition or not, really are shaped around what happens after church on a Sunday, outside of the COVID-19 era. I can remember growing up in Atlanta. I grew up AME, which is African Methodist Episcopal, and my sister and I knew which Sunday was which. We knew when they were serving cake. We knew that when they were serving chicken. We knew when they were serving different things, and that was kind of what helped us decide like how exciting that church service would be. Which is, you know, that was the framework of little girls, you know, in the church community. So some of the early research that I was doing back in the late 90s, early 2000 was really surrounding like approaching people where they were. I worked under, at that time, Dr. Ken Resnickow, who's at the University of Michigan. And one of his larger landmark studies that looked at nutrition within Black church communities was called Healthy Body, Healthy Spirit. And what we did was randomize several churches to either treatment or higher levels of treatment within the Atlanta community, and really went and took our healthy eating into the church community. You might say, okay, well, how do we approach that, you know, within the Black community? You have to use people that look like us. So Marla Gibbs was our spokesperson. You know, she was someone that people identified with. Our videos included other persons that were prominent within the Black community to deliver this messaging. Also, I think it was important that I was serving as the person that would get up and deliver those announcements at the Black churches. Ken Resnickow, who's a white male, that would not have gone over too well in many of the Black churches in the Atlanta area. So seeing people that look like me as a part and really entrenched in this work is important. We did another project called Go Girls, which was targeted at overweight and obesity within adolescent Black girls. And, you know, Go Girl was really kind of a thing back in the early 2000s. And that really, we brought in chefs every single week to teach girls along with their parents or whoever their person that was their caregiver about healthy eating. I taught their exercise classes. So we were doing things that would be hopefully sustainable, things that they could carry beyond that study period. And so I think when we're thinking about, you know, how we target communities, we have to think about going to people where they live and addressing them from a place that's culturally appropriate. Using the barbershops, we've seen those big studies come out looking at hypertension within Black men, using barbershops as kind of the place to deliver care, because Black men, not during the COVID era, but typically will spend a lot of time at the barbershop. So going to places where people exist, where they live, delivering that messaging within that setting, but in a culturally appropriate way, I think is what we need to be thoughtful of. And I think those interventions tend to be more efficacious than those where we try to cookie cutter something into an environment in which it won't be well received.
Listen, I think I'm going to constantly be learning from Fatima today. So let me just dovetail from what she just said. The late Ron Victor was one of the researchers who published in the big New England Journal of Study and a lot of the big studies around hypertension in Black men and controlling that in barbershop setting, really was kind of taking a page from the stuff Fatima is talking about, which is, you know, how do you utilize the social construct to create better clinical outcomes? And really even by that kind of community engagement, addressing some of those social terms of health dynamics, at least in how we engage those communities. And I was laughing when Fatima said this because we've been investing a lot in the hypertension study. But she is so right. Church, you know, food at church growing up was very definitional. You know, I was just laughing when he said it because you're right. I would do the same thing. We think about, you know, is it fried chicken Sunday? You know, we think about all these different contextual cues. And to Ed's earlier points, you know, those are the things that we pass on from generation to generation that we need to be both aware and understand the cultural dynamics. But one of the interesting things about what we learned from, so we've been investing particularly in Nashville and in LA around Black men in barbershop studies and trying to incorporate the ROI and some of the other things that allow these efforts to transcend just a study population, be rooted in terms of health interventions overall. And by far, I think they continue to show, at least pre-COVID, that it works. That if you set up and if you set up in a social setting that is comfortable, create the dynamics where people are able to kind of gain information, understand, and then intertwine that with clinically relevant both information and interventions, that those things pay off. So to Fatima's point, I think Ed alluded to this earlier, and even Derek was when he was touching on kind of the multifactorial concept. You have to meet people where they are. And in terms of best examples of social terms of health strategies, I would say the hypertension barbershop are some of the best kinds of things that one can grow in terms of, again, kind of clinically relevant and socially compelling intervention strategy.
Ed or Derek, do either of you want to jump in before I move to the next question?
I'm fine with going to the next question.
Okay. So talking about meeting people where they are, given COVID, and given it will unfortunately be here with us for a while, which means continuing social distancing, higher risks for sickness and death in communities of color, less physical activity, kids not having access to school breakfast and lunch, physical education, safe places to play. How do we help people navigate this public health crisis and period of high stress to both decrease their risks of contracting COVID while also working on ways to improve their health or at least prevent it from getting worse? We've made progress, but what is this going to mean?
So
Fatima,
for me,
do I have permission to talk?
Go ahead, Derek, and Ed will come right back to you.
No problem. So I was going to say that I think this is it's an interesting time, right? So you've got young people who are engaged in athletics that may not be able to do that due to the pandemic, and then you've got folks that we're trying to ensure that they remain socially distant, those that aren't as physically active as well. But folks are paying attention right now. So maybe this is a unique opportunity for us to, really stimulate and educate the masses around things that they can do both within their homes and hopefully within their neighborhoods that's both socially distant and respectful of what we're dealing with the pandemic, but also that gives them an opportunity to take better charge of their health and maybe even make them more resilient to infection in terms of managing, both their baseline health and any chronic conditions that they may have. And so as folks struggle with some of the mental impact of living through the pandemic, we may be able to offer them, again, some actionable things that they can do that helps improve their physical health during a time period where folks are really focused on overall health and also have legitimate fears and concerns. And so there may be an interesting intersection here that we can exploit to the benefit of the communities that have suffered significantly. Ed, I'm sorry, I didn't mean to cut you off there. Go ahead.
Oh, no, you're fine. So I wholeheartedly agree with what you just said. And I know for me personally, when I discuss things with my patients, the pandemic situation is tough. I mean, it's tough for not only us as physicians, as patients, but for just human beings in general. This is a tough time. So how do we navigate it? And my approach is similar to pre-pandemic. Whenever I see someone who's trying to lose weight, I always have a conversation about obstacles to weight loss. So I want to know what obstacles are in place that's going to make my life difficult. Or the patient's life difficult as far as losing weight. So with the pandemic situation, the conversation is the same. Now it's just another obstacle that we have to figure out how to get around, but it's good to understand those obstacles. And many of these obstacles, these are the social determinants that we're thinking about. And some of the obstacles can be physical obstacles. So if you live in a neighborhood where there's no access to areas where you can work out or walk safely, that's a physical obstacle. And there's financial obstacles. And so a lot of my patients may not necessarily have money to have gym memberships, et cetera. So I have to be aware of all those different obstacles before I start giving a weight loss prescription, so to speak. Because if my prescription does not understand the barriers that people are facing, then it's not a realistic prescription to some degree. So with the COVID situation, a lot of people don't want to be in gyms. A lot of gyms are closed down. So I understand it. I'm not advocating that anyone should potentially try to, go in a space that's enclosed and engage in a lot of exercise, because that may not necessarily be the safest space for you to do that, especially if you're in an area that has a high degree of people with COVID. So what I'm doing right now for the University of Chicago, we basically are outsourcing a lot of personal trainers where we're setting up our own weekly exercise schedule via Zoom that all the patients can have access to, not only patients within my weight management clinic or lifestyle clinic, but just the patients in general. So I am slowly getting more trainers involved where now it's just going to be a schedule. Monday, you got yoga classes, you have your little spin class, and anyone who has any resources to do some of those classes, they can just jump in wherever. And we're trying to offer those free. So that's one example of using your institution to address barriers that didn't necessarily, some of those barriers are new because of COVID, but also some of those barriers existed, pre-COVID. Other things that we're doing, so a lot of my cooking demos, so previously I was doing cooking demos in person at least once a month here in the hospital. And obviously with the COVID situation, we can't do that. So now I'm trying to figure out how to do that via Zoom and also online. And I'm not only working with the hospital, but I'm also working with community organizations such as Common Threads. So right now we're in the process of actually finishing a grant to get more money so we can not only do cooking demonstrations, but in this recognizing that more people are dealing with food insecurity right now, we're trying to not only do the cooking demonstrations, but also provide the food for the demonstrations. But that takes funding, and it also takes collaboration. So I think that is a good example of using academic and community collaboration to actually address some of these issues that are popping up now.
And, I want to, echo what Ed said with regards to a lot of these things we're doing to get patients access. The problem is that, and this is really kind of the overarching problem that I see, is that when we're looking at telemedicine or telehealth access, that in communities that are low resource, they don't have access. So what I'm even noticing with delivering care via telemedicine for my patients that come from lower socioeconomic status, my older patients, they really have a hard time accessing care through this venue. Maybe they don't have an appropriate Wi-Fi signal. These are types of things. I've heard of some cities that are beginning to basically write prescriptions for Wi-Fi for their patients, basically, which I think is an amazing strategy, right? Like if we can't get the patients on to do a Zoom workout or whatever, none of this matters. And we're seeing education suffer, right? We're finding that those individuals that don't have access to the Wi-Fi to get on to their hybrid model for, elementary school, middle school, or high school education suffer because those that are coming from a middle or upper class background already have that just as status quo within their household, are able to access that education. And so we're seeing this, I think what we're seeing is a widening of disparities as we've gone into this era of COVID. I think these are some of the things that were brought up by Dr. Graham earlier, like that we're going to see this reverberation go for many, many years as we start seeing widenings of disparities, which are secondary to education, access, and things of that sort. So I think we need to be thinking about these population level strategies to really help our patients. The idea of us accessing and people having better access to us via telemedicine is really a certain cohort of individuals, cohorts that have access, that are able to, have the luxury of working from home, that aren't on the front lines of either delivering healthcare or essential workers, whether that be persons that work on the subway or whatever it might be. They don't have the same level of access. And so that then permeates to their children, which then permeates their overall health. And so we have to be mindful of how do we fix that? Because that is a population level strategy, because this is something that we're seeing in Chicago, that we're seeing here in Boston, that we're seeing all over the country. And we really need to be thoughtful about this as we recognize that a lot more of our care, a lot more of our access will be delivered via this telehealth portfolio that we'll see.
Fatima is exactly right. And, Derek said something which I want to pick up on, because Derek was really correct with this. We have to use this time period to make some change. I can't think of another time period, at least in my career, maybe the 60s, it was the only other time in history that I know of, recent history, where we have such national engagement around these kinds of issues. And, particularly, people are running stories in the media around the disparities of COVID-19, as if it's all this stuff is brand new. Which as Ed pointed out, and Fatima had said as well, and none of this stuff is new. These are just evolving parts of the same problem. So, but I do think that if at the very least, and maybe through conversations like these and other efforts that a lot of us are all involved in, at the very, very least, this is probably the time that, as health and public health are part of regular nomenclature now, regular conversation that my mom is talking about. Then now is the time to think about how do we change some of these things that we've never had the chance to change before. And that's just my one point I want to add is as Derek pointed out, just kind of taking advantage of, somebody in politics from Chicago who said, never let a good crisis go to waste. And trying to figure out how we use this to kind of elevate the discussions.
I want to add one thought that Fatima reminded me of. We began opening Blue Door neighborhood centers in Chicago, starting on the far south side. And one of the most popular aspects of that community asset were exercise classes that many of our senior citizens became involved in. And now, as we're pivoting to COVID, we are beginning to do those virtually by Zoom. And so, this may be an opportunity that we could even leverage together, as you have more patients that maybe aren't able to do it in person, that we could leverage some of those classes to get more individuals throughout the community involved, because I think we can certainly serve more people than we can serve in 1, 2, 3, or 4 physical locations virtually. And so, notwithstanding the risk for the digital divide that Fatima spoke of earlier, this is again an opportunity where we could leverage this crisis and exploit it to the benefit of the health of the communities that we're talking about.
That sounds great.
We have about 6 additional questions from the audience, but my last question, if we could just do a quick firing of ideas, but can we talk about multi-sector strategies? We just got into it a little bit, but which really integrate government, industry, educators, faith-based communities, media, just to address the issues of health disparities right now?
So, I think that we've definitely touched on that, Linda, throughout the conversation today. What we've learned throughout this conversation, and what we've learned before, is that it's going to take a multidisciplinary, multi-sector approach to really address these social determinants of health, especially as we're thinking about issues such as overweight and obesity, which are systemic chronic diseases. There is not one sector that's going to have all of the answers. So we see that there are great answers coming from certain sectors, but if we don't have that as one cohesive, concerted strategy, then we'll continue to fail. We'll continue to see rates of obesity climb both in the pediatric and adult population, and we'll continue to see disparities exist. So we need to come up with a dedicated, concerted strategy. There is no national treatment strategy for obesity in the United States, which is quite disconcerting when we look at the fact that our rates of obesity in both our pediatric and adult populations really tower over many other developed countries. So we need to be thoughtful about that. We need to be thinking about what's happening at the government level that does set the course for what we see in other sectors. But we can't, as us, those that aren't in the government sector, allow our communities to go underserved as we wait for the government to do something. So we have to begin to develop those strategies that can be sustained over time. And I think that's when we'll really begin to see some measurable change regarding social determinants of health, regarding those chronic diseases, particularly obesity, which disproportionately affects Black and Brown communities.
I definitely agree. So I think I would add that we should also, from a governmental perspective, try to look at who has access to dietitians. So even having access to a dietitian is a privilege that it's not shared equally. So depending on your insurance will not cover you to see a dietitian unless you have a comorbidity like end-stage renal disease where you're on dialysis, or you have diabetes, or poorly controlled diabetes specifically. And for everyone else, if you have overweight and obesity and you just want to see a dietitian to talk about different dietary strategies, you may not necessarily have access to a dietitian, and you may have to pay out of pocket to pay that dietitian. So a lot of insurance companies, when it comes to approving someone for access to a dietitian, they may follow just whatever Medicare is doing. And Medicare, again, is not saying everyone has equal access to a dietitian specifically. And that's a problem. We live in a country where there is a significant amount of people who are dying from nutrition-related conditions, yet the majority of the people do not have access to a dietitian. And that's something that has to change, not only in terms of at an institutional level, we have to, as hospitals and clinics, be able to provide those dietitians, but on a government level and even a business level, we have to figure out how to pay for those services and ensure that people get reimbursement for those services. And that's something that requires lobbying to some degree. So I have had the ability and the privilege of talking to some of my elected officials, both locally and nationally, to advocate for this specifically, but it takes more than just me as an individual. We really have to get not only community organizations and other institutions involved, but we have to be on the same page in terms of addressing some of these needs.
I would agree with Ed. I think, and Fatima, we've got to be all in. There's not going to be a single sector that can solve it. We have to get outside of our traditional swim lanes and pull some levers that maybe we didn't traditionally pull to advance us forward. But I think it's going to take a commitment across the board to make some things happen.
It sounds like there's a need to create a new organization. Dr. Cody Stanford, there's a question for you. Is overweight and obesity passed down? Is it passed down through genetics? I guess this goes to the biology question. Could you explain the science of that quickly?
Well, that's going to be hard to explain quickly. I usually do 5 slides at least. But what I want to explain is this concept of fetal programming, which is if a mom goes into a pregnancy with overweight and obesity, she has increased inflammatory markers within. For those that really want me to drill deep, IL-1, so interleukin-1, IL-6, TNF-alpha, MCP-1 are all elevated if a mom has obesity going into pregnancy. That then leads to downstream impacts on the fetus, where we see an increase in fatty liver coming out of just the fetus, even from exposure to in utero inflammation, meaning the inflammation that the mom has while she's in pregnancy. Now, this can actually be modified. And there was a large study that came out in the Journal of Clinical Endocrinology and Metabolism back in 2008, where they did what's called a prospective study. And they basically looked at moms and looked at the children born to the mom pre and post her having bariatric surgery. So same parents, pre and post bariatric surgery, looking at the child born after surgery, which is when mom had modification in her weight status, versus prior to that. What they saw in that study, which I think has been the best landmark study, was there was a 3-fold decrease in the prevalence of severe obesity in that child born after surgery compared to the mom born before the child born before surgery. So we were able to modify the mother and then modify the weight status of that child post pregnancy. Macrosomia, which means being born with a very large body as a child, usually over 3,500 grams is what we would look at in pediatrics. We saw an 8-fold decrease in that just at the time of birth. And not only did we see improvements in just size, there was actually improvement in insulin, ghrelin, which is a hormone that stimulates hunger, leptin, which is also a hormone that plays a large role in how our body regulates weight. There was a significant difference between the older child to the younger child with no significant changes in genetics because the parents were the same. So what that tells me is that we can then modify these parents, which then modify the offspring. Yes, lifestyle factors play a role, but the genes are much stronger, and study after study have shown that, including early landmark studies in the 1970s coming out of the New England Journal. We've continued to see this perpetuated. So what we also know is if you have overweight and obesity, that triggers actually parts in your brain. So if you were to do a functional MRI scan, so a scan looking at your brain in terms of what hyperreactivity you have, a lot of that's genetically determined. Whether or not you walk past a pizza store and want to go in, that's not all the environment. Yes, the environment's there. So if you pass it, then you may be more likely to be influenced to go in. But some of it's just your hyperreactivity to food cues, which is based largely on how your brain is set up. How is your hypothalamus signaling? Is it signaling down an anorexigenic pathway or orexigenic? So I told you guys, you asked me to go there. It's really tough stuff. You can just attend another lecture and I'll go over it in full detail.
Thank you, Dr. Stanford. There's 2 questions that I'm going to combine. Catherine Pett asked, could there be opportunities for improving healthy food access by putting frozen or fresh food choices in neighborhood corner stores? This one might be for you, Garth. And Erin Fisher actually pointed out that local efforts like healthy corner store projects or active transportation initiatives incentives haven't necessarily translated into a decrease in obesity rates. Can you talk a little to that, Garth? Thanks.
Yeah, that last point is a key point. So, we've invested a lot in these kinds of the first questions effort and trying to increase the availability through kind of corner stores or kind of other retail settings. And this is an investment that has gone on in a variety of different ways, even particularly in DC and some other markets. That last question is something that we have not necessarily seen all in our data, but you see for some of the national data where these kinds of efforts don't always result in either market pickup or necessarily behavioral change. And, it touches on some of the stuff of Dr. Cody mentioned, Fatima mentioned, around, the multi-tiered factor around behavioral change. And just kind of opening up and making it present does not all of a sudden make people react appropriately. But what I do think is that the onus of responsibility, especially folks who have the ability, is on us to try to make those options available, realizing that engagement and other kinds of things needs to go along with it. And that probably goes to the multifaceted aspect of investment and change that needs to happen to really combat some of these both societal and then as Fatima is teaching me here, chemical and other kind of cytokine related dynamics.
Thank you. I'm gonna combine 2 more questions again, and Ed and Derek, if you want to talk to this. Sherry Mermelstein asked, she pointed out in Black and Brown communities, excess weight is more acceptable and weight loss doesn't necessarily resonate as a motivating factor. She's found this as a registered dietitian. She'd like your insights and thoughts. And I guess, Ed, if you could also address perhaps maybe how one of those solutions has been your initiative with Project Brotherhood and what you've done with a lot of the your initiatives in the barbershop, other than necessarily just like leaving pamphlets to kind of speak to that.
Gotcha. So as far as excess weight, it's very complicated. I mean, there's been studies that have demonstrated that standards of beauty may have cultural influences that may not necessarily be the same in different communities. And to some degree, that's a healthy aspect. And when you look at body mass index overall as a marker or measure of having obesity, to some degree, it's very complicated. Okay, so there have been plenty of studies that have demonstrated that using the same numbers for people of different backgrounds in terms of defining what it means to have obesity or have overweight based upon BMI may not necessarily be the best measure. It's one of the metrics that we use because it's easy to ascertain. But when you look at different studies, particularly there was one study that looked at how BMI correlated to having cardiometabolic risk factors for like heart attacks and strokes, et cetera. So they specifically were looking at BMI as it relates to having high blood pressure, high cholesterol, and fatty liver disease, and people with various BMIs, and what they found, and also various cultures. So what they found was for African American women, they didn't have two. They started to have, on average, 2 metabolic risk factors at a BMI of 33, as opposed to a BMI of 30 that was seen in Caucasian women. And a similar study was done where they looked at variations in muscle mass in women of different backgrounds. And that what they found was they used a DEXA scan to identify how much muscle someone had compared to fat. And they found that for African American women, even at a higher BMI, they had more muscle mass as opposed to fat mass. So the fat mass is the what we're concerned about, because that is metabolically active and potentially, especially depending on how the fat is distributed throughout the body, can put people at risk for conditions such as heart attack, having high cholesterol, high blood pressure, et cetera. But the BMI as a metric does not necessarily pick up all that information. And I've even done one study where we used NHANES data to review some of the questionnaires that they asked people. And one question was, do you view yourself as having overweight or being obese? And what we found for African American women specifically in the overweight category, majority of people did not view themselves as having overweight. But if you look at BMI, based upon BMI, they may not necessarily have any within that number. They may not necessarily have any of the health issues that we associate with having overweight or being obese. So, you know, it is something that I personally try to navigate carefully, because on the one hand, I don't want to engage in fat shaming, and fat shaming of itself is a problem, and it's something that we definitely do in our society. And for many people, experiencing fat shaming in and of itself can be a social determinant of health and an obstacle to losing weight, based upon several different research studies. So I really try to encourage people to live a healthy lifestyle. So I focus less on the weight and more so on the lifestyle. And a lot of times when we start talking about just things people can do to live healthier, a lot of times when we start engaging in some of those things, sometimes the weight can decrease. Now, in certain situations in which people need bariatric surgery, et cetera, that, you know, some of the definitions in terms of who's a candidate for bariatric surgery does involve BMI. But even still, I still encourage people to try to live this kind of healthier lifestyle to some degree.
And I'll contribute to this question with a great humility, appreciating the expertise that we have on the phone. I think when we talk about image, weight, beauty, and self-esteem, it is very complex. And, you know, I guess I would say that many of the factors that contribute to individuals being overweight, it's probably a lot easier to occur in the African American community, just based on the many of the social factors that we've talked about today. And perhaps there's some healthy component to individuals feeling good about themselves versus feeling negative based on a standard that has been set by society. But certainly we want to ensure that folks are able to reduce their risk for a variety of different chronic medical conditions, including obesity. And so I think it does have to be handled with professional care and guidance, such as what's been shared on the call today. But I would say that it's a complex discussion that should be handled with care in order to achieve the outcomes that are best for our patients. And ditto everything that Ed said.
Well, thank you all so much. We have probably about 20 more questions that have been chatted out. And I know we could probably get into an entire other panel just along overweight and obesity bias. So I perhaps will have to schedule a follow-up, another follow-up panel. But I just want to take another minute to thank my esteemed panelists. You all are so wonderful and have been so wonderful to me and Common Threads. And I'm just so grateful that you all made time and space for this really incredible and thoughtful conversation. Thank you, thank you, thank you.
Thank you for having us.
Thanks for
having us.
Yeah, thank you.
Have a wonderful day, everyone, and thank you to everyone who tuned in. We're so glad to have you as part of this conversation. Have a great day, everyone.
All right. Take care.